Okay, my dear friends, I'm extremely honored, extremely happy, extremely proud to give you my presentation. And I am going to touch a new thought in the field of spine surgery. You see, whenever we talk of spine, whenever we discuss spinal surgery, we talk of compression and we talk of decompression. So decompression is the aim. I am saying that compression is not the problem and decompression is not the treatment. So this is a very dynamic and very revolutionary statement that I am making, and I wish to discuss this statement. I am introducing to you a concept. I am introducing to you a concept that instability is the issue and stabilization is the treatment. So if we talk of these animals, you see this is a four-legged horse. The problem is that there is no weight on the spine. The entire muscle bulk is on the four legs. Similarly, in this bird, the muscle bulk is on the wings. The spine is quite okay. But when we talk of a human being, the entire muscle bulk is on the back of the spine, paraspinal. Throughout your life, you stand and run. Weakness of the muscles of the back is the initiator or the nodal point of genesis of spinal degeneration. And when there is a weakness of muscles, there is vertical spinal instability. And this is the point of genesis of spinal degeneration. So to come to this point, I will like to go in the history of this understanding. Basilar invagination 20 years ago was considered to be an anomaly. Decompression was the treatment. It was considered to be a fixed issue, and decompression either from the mouth or from foramen magnum was the treatment. We introduced a completely new concept that decompression is not the treatment. It is an unstable spine. It is not a fixed atlantoaxial dislocation. It is unstable, and the treatment is stabilization. And if you can achieve realignment, that is the best form of treatment. So for the first time in the literature, we said decompression is not the treatment. And now we have hundreds of these kind of cases where there is basilar invagination. We know that this is an unstable spine, and we also know that stabilization and realignment is the treatment. So this was my first case 21 years ago when I did this realignment. You see no transoral decompression, no foramen magnum decompression, and now I have got several hundred cases where I have not done any decompression from front or any decompression from behind. Instability is the issue, stabilization is the treatment. Rotatory dislocation. Those who are in this business of craniovertebral junction know that for rotatory dislocation, there was no treatment 20 years ago. There was only one treatment, and that treatment was decompression. So we introduced this concept that open the joint, realign the facets, realign the joint, and you can reduce rotatory dislocation into a long and straight neck. So no decompression, stabilization. So we have treated several patients like this where we have done realignment of craniovertebral junction for rotatory dislocation. This is a traumatic fracture and the facets are disrupted. So there is no other treatment but to open the joint, realign the facet and stabilize. So decompression is not the treatment. Stabilization is the treatment. And if you can realign, that is the best. Fixed atlantoaxial dislocation or irreducible atlantoaxial dislocation was a common clinical entity 20 years ago. We introduced this concept that there is nothing like fixed dislocation. All fixed dislocation can be reduced and realigned. So this was the, I think, the most remarkable paper in the journey of craniovertebral junction. Flexion, extension, no movement. The treatment was decompression, but now there is no decompression. Stabilization is the treatment. These are not fixed, these are unstable anomalies. So there is no need for decompression, stabilization, and realignment is the treatment. Basilar invagination, instability is the cause, and vertical instability is the cause, and stabilization is the treatment. I have no hesitation to say that I completely demolished transoral surgery from the domain of neurosurgery. Facets are the fulcrum of movements. All the movements of the paraspinal muscle is focused at the facets, and facetal issues are the primary issues. Lumbosacral listhesis is similar to C1 over C2 listhesis. So this listhesis is the cause of basilar invagination. It is an unstable situation, and stabilization is the treatment. So when there is Chiari, syrinx, and other anomalies, and basilar invagination, assimilation of atlas, you see the listhesis, C1 over C2 listhesis. Treatment is by stabilization and not by decompression. No anterior decompression, no posterior decompression. I introduce another dramatic and probably a revolutionary concept of central atlantoaxial instability. Now carefully see at these slides, you see type 1 is when the facet of atlas is in front of facet of axis. This is an unstable spine. Atlantodental interval is increased, cord is compressed, listhesis is there, stabilization is the treatment. This is now, we know this. Type 2 is a very interesting form of instability. Facet of atlas is behind the facet of axis. This kind of huge basilar invagination, there is no need for any kind of decompression, no foramen magnum decompression, no transoral decompression. This is unstable. Stabilization is the treatment. We also introduced a third kind when the facets are in alignment, but presence of Chiari, presence of syrinx, presence of assimilation of atlas, presence of Klippel file abnormality, presence of platybasia are all indicators of unstable spine, and it indicates the need for stabilization. So for basilar invagination and all its components, stabilization is the treatment. For both group A and group B, there is no decompression, only stabilization, and all those who are in craniovertebral junction know that many people in the world now follow this concept. So there is no atlantodental interval disturbance, but there is type 2 facetal alignment, malalignment. There is Chiari and syrinx. There is no other treatment, no decompression. Stabilization is the treatment. You stabilize and the syrinx goes and the tonsil goes up. More important than anything in the world, the patient improves remarkably. No decompression of any kind, even when the facets are in alignment, even when there is no atlantodental interval disturbance, there is no tight posterior cranial fossa. I introduced this concept of tight posterior cranial fossa in 1997. Today I am saying there is no tight posterior cranial fossa, there is no tonsillar herniation which is compressive. It is an indicator, it is a protective phenomena, it is an indicator of atlantoaxial instability, and stabilization is the treatment. Syrinx will go in 100% of cases if you do a scan after 1 year. Stable, solid fixation is the treatment. If you do flimsy stabilization, it will never improve. You have to do open the joint, put bone graft in the joint capsule, and then do stabilization, and you see the magic. You see a magic like you have never seen before by decompression. You see no decompression, only stabilization is the treatment, and more important than syrinx reducing, the patient will magically improve in the immediate postoperative period. Basilar invagination, Chiari malformation, syringomyelia are all indicators of atlantoaxial instability. And you know this article, we mentioned that is atlantoaxial instability the cause of Chiari malformation? Yes. Is atlantoaxial fixation the treatment? Yes. Decompression is not the treatment. And recently I published my series of 388 cases. You see the paper, remarkable clinical result. I call it magic. So when there is atlantoaxial instability, there are several things which nature does, which God does. One is Chiari malformation, and Chiari tonsil is introduced like airbag, and we have said that Chiari is like airbag, and it is diagnostic of atlantoaxial instability, and atlantoaxial stabilization is the treatment. Cervical fusions are also indicators of atlantoaxial instability. They are protective. These are secondary. They are not problem, they are solutions. Bifid anterior and posterior arches are not pathological. They are secondary, they are protective, they are dynamic, they move on flexion and extension, and they indicate the presence of atlantoaxial instability. Even when there is no compression at the craniovertebral junction, presence of multiple fusions, presence of bifid are indicator of instability of atlantoaxial joint and the need for stabilization. Os odontoideum is also an indicator of atlantoaxial instability, is also secondary, is also a protective phenomena. You see this os odontoideum, there is no need for any decompression. There is only the need for atlantoaxial stabilization. Any kind of decompression will be harmful. Syringomyelia is also an indicator of atlantoaxial instability. You do stabilization and the syrinx will disappear. Syrinx is a natural protective phenomenon. You see, there is a syringomyelia, there is no atlantoaxial dislocation, minimum type 2 atlantoaxial facetal instability. You stabilize, you give new life. You do any kind of shunt, any kind of decompression is a harmful procedure. Musculoskeletal abnormalities are also indicators of atlantoaxial instability, and they reverse. They are protective, they are secondary. Short neck, torticollis, they are secondary protective. Muscle spasm, platybasia, Klippel-Feil abnormalities are all secondary. You do atlantoaxial stabilization, the neck increases in size and the neck becomes straight, and you see the beautiful smile on the third postoperative day. So this smile continues in a little bit different fashion. You do atlantoaxial stabilization and you see the magic, and you see a beautiful magic. There is no need for decompression. Kyphoscoliosis, another beautiful thing. You have seen a short head and torticollis. I am saying there is short spine and kyphoscoliosis. Kyphoscoliosis is almost always, now listen to me carefully, kyphoscoliosis is almost always due to atlantoaxial instability. You do stabilization and you see the back will become straight. There is no need to do multi-level fixations and multi-level fusion and a number of screws and number of rods. In almost 100% of cases in young individuals, atlantoaxial instability is the cause. You can make these patients kings if you understand the atlantoaxial instability, no decompression. Another beautiful entity is central or axial atlantoaxial instability, and it can cause various kinds of anomalies if you try to understand huge kind of syncopic attacks, headache, hearing problem, dizziness. There is no compression and there is no decompression. There is central instability which is indicated by bifid spine. There is central instability which is indicated by various telltale evidences. You identify instability, you treat instability, you give new life. I am telling you, you will give a new life, which is the most wonderful life the patient will have. Like this patient, you see the hand is not moving. In the immediate postoperative period, this is inside the operation, this just inside while she was admitted, the shoulder has come back to normal and she has got an absolute new life. Foramen magnum decompression, can it become historical? Absolutely, decompression is never the treatment. Now I want to take you to beautiful spinal degeneration. I have done a lot of work on anterior surgery. I wrote this chapter on Sweet and Smidek book, and I had various types of technique for corpectomy and all. I had this technique I described about 25 years ago, these tricortical screws of various kinds and various permutation and combination. But today, I am saying, disc is never the problem. Disc degeneration is never the issue. Muscle weakness, and muscle weakness due to disuse, abuse, injury leads to instability at the facets, and facial instability is the primary issue in spinal degeneration. Craniovertebral degeneration is the most common form of spinal degeneration. When we talk of degeneration, we talk of C5, C6, C4, 5. We never talk of C1, C2. I am saying C1, C2 instability, C1, C2 degeneration is the most common form of degeneration. When there is atlantoaxial degeneration and there is an unstable atlantoaxial joint, bone formation is a secondary event. Now carefully look at this slide. Reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation are not primary events. They are secondary to vertical spinal instability, atlantoaxial instability, and atlantoaxial stabilization is the treatment. Removal of osteophyte, removal of this ligament are negative operations. Bone formation in the apical ligament is not a primary event. It indicates atlantoaxial instability. It indicates that you have to stabilize the atlantoaxial joint. It indicates that there is no need for decompression from front or from behind. It indicates that there is atlantoaxial instability. Retroodontoid pseudotumor. The whole world was removing by transoral, lateral route, various other routes. Decompression was the treatment, either anterior or posterior. For the first time in literature, about 20 years ago, I said that these are like osteophytes. They indicate unstable atlantoaxial joint and they indicate the need for atlantoaxial stabilization. This paper was the first in this era saying that retroodontoid tumor is an indicator of atlantoaxial instability. Now I have got several patients of such kind, and many people in the world are referring to this philosophy. Retroodontoid cysts are also secondary. Cyst removal is very easy, but there is no need to remove this cyst. It indicates an unstable atlantoaxial joint. It is a protective phenomena. You do stabilization, the cyst can disappear in the immediate postoperative period. I have got several cases like this. Retroodontoid cyst, you see unstable joint, you do stabilization, there is no need to touch the cyst. So we have to understand what is primary, what is secondary. Treat the primary, respect the secondary. Secondary is always protective. Secondary is never harmful. This cyst is not harmful. It is protective. Don't do decompression from front. Don't do decompression from behind. Stabilize the joint and you see the miracle. Os odontoideum. You see os odontoideum, there is a cyst behind the C2 body and there is a hole in the body. We said that there is a dynamic phenomena. When you do flexion, the retroodontoid cyst goes inside. There is a movement. And I said that this retroodontoid cyst is a protective phenomena. You see, there is a retroodontoid pseudotumor and there is a defect in the bone. We said that this is dynamic. You do stabilization and this is finished within 1 week of surgery. So retroodontoid and retro C2 body pseudotumor, pannus, and cyst are protective. They are not harmful. They are indicators. This is pannus. If you realize for 20 or 25 years, people were removing this pannus by transoral route to decompress. These are buckling of the posterior longitudinal ligament. You do atlantoaxial fixation, you do distraction, and this cyst finishes in the immediate postoperative period. We introduced intra-articular spacers for the first time in craniovertebral junction. Now I want to show you its use in the cervical spine. So we have talked about C1, C2. Nobody in the world talked about facets of the spine. Facets are the prime movers. They are the nodal point of movements of the spine. Do not ignore the facets. Respect the disc. Treat the facet. Respect the disc. I am saying the disc can never be a problem. Disc is always a solution. Reduction in the joint disc space is not primary. It is due to vertical facetal instability, buckling of the posterior longitudinal ligament, osteophyte formation, multi-level bulges are not primary problems. They are indicators of an unstable cervical spine, an unstable lumbar spine. It merits the need for stabilization and no need for decompression. So vertical instability is the point of problem. You see, we introduced about 12 years ago or 13 years ago intra-articular spacers. This is in the history of my journey towards treatment. You see, this is a large osteophyte. I introduced a spacer. Immediate postoperative, the ligamentum flavum bulging is gone, the posterior longitudinal bulging is gone, and there is a new disc formation. So we introduced a new hypothesis for spinal degeneration, and we said that muscle weakness related facetal listhesis is the problem and the nodal point of genesis of spinal degeneration. You see, there is posterior longitudinal ligament, ligamentum flavum bulging, and the whole thing is gone. There is no compression. I have done multi-level facetal distraction and fixation. Similarly, here you see there is an osteophyte. There's a new disc formation. Ligamentum buckling is gone. Posterior longitudinal buckling is gone. Most important is you can do multi-level fixation for radiculopathy, for myelopathy, for single level, for multi-level, and what your aim is ultimately arthrodesis or fixation without decompression. Decompression is not the treatment for multi-level spinal degeneration. Stabilization, fixation that aims towards arthrodesis is the treatment. So I have got several cases like this where I have done only stabilization, and we have got tremendous remarkable clinical result. And as you know, many people in the world are now following this concept that there is no need for anterior surgery, no need for decompression. You do stabilization with facetal distraction, the compression will be gone, and the patient will remarkably recover. So these are multiple patients. You see there is compression, and you see postoperative new disc formation, increase in the disc space height, increase in the interspinous height, and ultimate aim is stabilization. So this we introduced a concept that muscle weakness and facetal listhesis is an issue. And we published this article 10 years ago on the cover page of Journal of Neurosurgery, and facetal distraction as a treatment. So this was a new hypothesis for spinal degeneration, and according to me, without any doubt, a revolution in spine surgery. We introduced these facets spacers, which are named as Goel facet spacers, and they have been patented a number of times in US and in India. I have got 23 patents for this. So there is a disc herniation. You see, there is a disc herniation. The whole world will do decompression and removal. There is a possibility, and distinct possibility, you distract and the disc will go back into its space. And we have published the same concept I use for lumbar canal stenosis. Lumbar canal stenosis and bulging of osteophytes and ligamentum flavum bulging are not primary events. They are due to vertical spinal instability, and facetal distraction can be a beautiful form of treatment. I published this article 10 years ago, and you please refer to this article. Now I go to another chapter in spine surgery. Decompression of the compressed and deformed neural system has been the basis of surgical treatment for several decades. I am saying this is a wrong concept. There is no compression and there is no need for decompression. Only fixation for cervical spondylosis. And recently I published my experience with 215 cases where I said muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment. There is no word decompression in this. There are multi-level osteophytes here and here. The whole world will do either corpectomy or decompression, and some few people might, not many, may like to do laminectomy, which was a standard, gold standard treatment in the past. But I am saying these are indicators of an unstable spine. They need only stabilization and no decompression. You see these osteophytes, and these are completely gone, and this is in very early postoperative period. I have not done any decompression. I have used the bone from here to achieve arthrodesis. So there is a possibility of treatment by only fixation. You see, there is short neck, there is increased hyperlordosis, there is muscle spasm due to chronic instability. You stabilize and the whole system becomes normal, the osteophytes regress, and there is no need for decompression. I am saying instability is the issue, and stabilization is the treatment, and decompression is a negative form of treatment. This multi-level compression, multi-level decompression is not the treatment. It indicates a weak spine. It indicates unstable spine, and you stabilize and you see the whole system returns to normal, and there is not a spicule of bone, not a spicule of disc, not a spicule of ligament has been removed, and the aim of surgery is stabilization. So cervical degeneration, the treatment is stabilization. The cause is instability. Osteophytes, ligamentum flavum, posterior longitudinal ligament thickening, disc space reduction are all secondary event. Instability is the cause of symptoms and stabilization is the treatment. Not neural deformation or compression, but instability is the cause of symptoms in degenerative spine. Most important is to find out which segment is unstable. Only compression is not the indicator of instability. Clinical parameters, radiological parameters, you see multi-level problem here. There is only 2 levels are seen here, but I have done 4-level fixation because the joining segments were also unstable. Most important and most critical is the understanding of which level is unstable and which levels to be treated. You see multi-level, the whole system is normal, and there is multi-level stabilization. There is not a single form of decompression. I am saying decompression is not the treatment. Decompression is harmful. Another most beautiful thing that you will like to hear is atlantoaxial instability is very common. Atlantoaxial instability is very common in multi-segmental cervical spondylosis. And if you see there is multi-level cervical spondylosis, there is type 2 facetal instability. If you do not include atlantoaxial joint in the fixation construct, you may not treat the patient. When there is multi-level instability, there is almost always type 2 atlantoaxial fixation or type 3 atlantoaxial fixation instability, even in the absence of compression, and you have to include C1, C2 in the fixation construct. In severe myelopathy, atlantoaxial instability is almost always present, and you must include atlantoaxial joint in the fixation construct. No decompression from front, no decompression from behind. I introduced this alternative technique of C1, C2 fixation, where I do transarticular C2-3 fixation and remove the C2 spinous process, which stabilizes the C1, C2 joint. So multi-level degeneration, even when there is no compression, there can be atlantoaxial instability, and you must recognize this fact. Multi-level degeneration, no compression, but I have included atlantoaxial joint in the fixation construct. And I have got several hundred patients of this kind, and I have no hesitation to give my young friends this message that do not decompress. Decompression is not necessary. Same concept I extended to lumbar canal stenosis, and read the title, Analyzing the Role of Stabilization and the Futility of Decompression. And this was published in Neurosurgical Focus, where I'm saying that for lumbar canal stenosis, it is a multi-level instability and you need to stabilize. There is no need to do any kind of decompression. You stabilize multi-level, and transarticular camillage technique I have used, and you see the magic. You will enjoy the magic. Bone removal is very easy, but bone removal is not necessary. Disc removal is very easy, but it is harmful. Osteophyte removal is easy, but it is absolutely not necessary. So what is necessary is stabilization, and you see the magic in lumbar canal stenosis. which segments are unstable. If there is no compression here, does not mean that this segment is not unstable. Identify which level is unstable and stabilize. There is no need for decompression. So I have got several videos here, but unfortunately they are in Indian language and you will not understand. So this kind of multi-level disc bulges are secondary phenomena, and what is required is stabilization and not decompression. So I have got several articles which you will like to read. So another issue is, do you need to resect the osteophytes in spinal degeneration? I am saying it is not necessary. You stabilize, the osteophytes will disappear. You see this preoperative, postoperative disappear. So I published recently my work on multi-level spinal degeneration and the outcome of osteophytes. You must read this article. Beautiful article. Multi-level osteophytes, only stabilization. And you see in 6 months, the entire osteophytes have disappeared. There is arthrodesis of multiple spinal segment. Osteophytes at multiple levels. I have done only stabilization and you can see the osteophytes disappearing. So osteophytes will disappear. Osteophytes are secondary. Osteophytes are introduced by nature in response to instability. They are natural protection. They are good for the patients. They are not harmful. So should you use the term spinal canal stenosis, I am saying this takes you to wrong direction. You should use the term spinal instability. This kind of kyphosis, you see, this kind of kyphosis is not the primary issue. There is atlantoaxial instability in this patient. You treat atlantoaxial instability and there is no need to do any kind of decompression. When there is no atlantoaxial instability, there can be type 2 atlantoaxial instability. And the entire segment is unstable and multi-segmental stabilization is the treatment. No decompression is necessary. So we have got several patients of treatment of kyphosis. It indicates multi-segmental instability and it indicates the need for multi-segmental stabilization. I introduced to you, my dear friends, another fantastic, probably in your mind, a revolutionary concept. Herniated disc is a manifestation of an unstable spine. Herniated disc is either due to instability of spine or herniated disc causes instability. You treat herniated disc not by disc removal, not by microdiscectomy, not by this kind of discectomy or that kind of discectomy. What is required is stabilization and there is no need for decompression. You see there is a disc herniation, there is single level disc. The whole world will come from front and do ACDF and all those kind of things. I'm saying identify the unstable segments, stabilize the spine. This disc will disappear in no time. There is no need to struggle with disc removal. There is no need to struggle with disc removal here. There is no need to do any kind of bone work or any kind of discoidectomy. So I published this article on cervical instability as a fascial fixation in cases of radiculopathy. I wish, my dear friends, you please read this article. Same concept I use for lumbar disc. Very revolutionary. Probably you may not really like this, but there is a real potential of an absolute revolution. So there is a disc herniation, and you see there are indicators of unstable spine, unstable facets. So I do fixation, and you see in 3 months the disc has reduced in size. Patient will improve in the immediate postoperative period, and that is my guarantee for you. You take it from me. You don't have to remove the disc, and you see after 3 months the disc will disappear. After 6 months, in 100% of patients, the disc will eventually disappear. You see pre-op and you see post-op. Which level is unstable? It is not that where the disc has herniated is only unstable level. Even adjoining level may be unstable. You see, I have fixed adjoining level. The main issue is to identify which levels are unstable on the basis of clinical and radiological assessment, and osteophytes and disc bulges are radiological indicators of instability. You have to have clinical indicators, and then you have to do spinal stabilization as treatment for prolapsed disc. There is no need to do discoidectomy. Another remarkable, magical, probably not probably, 100% revolutionary concept I am giving you today, ossification of posterior longitudinal ligament, is secondary to an unstable spine like spinal spondylosis. I used to do multi-level decompressions, anterior surgery, corpectomies, and all those kind of things. And I had introduced for the first time in literature oblique corpectomy in the year 2005. But today, what I am saying is it is not necessary. No corpectomy, no decompression. Atlantoaxial instability is a very common phenomena in high OPLL. In high OPLL, when it is high, atlantoaxial instability and subaxial instability are the causes of OPLL. There is no need to do decompression from front, no need to do decompression from behind. What is required is to identify the unstable spinal segments and do spinal stabilization. So you read the title of this article, is only stabilization the ideal treatment for OPLL? Long time ago, I had written this article, and more recently, I published my series of 52 cases where I have done only fixation. And I can tell you, my dear friends, most of you are young participants. I can tell you, my young participants, accept this change. If you don't accept it today, you will certainly accept it tomorrow. Think about it. Just don't go on removing bone after bone and disc after disc. It is not necessary. Do not touch the osteophytes. They are divine phenomena. When you see osteophytes and when you see OPLL, you think about unstable facets and you have to do atlantoaxial and subaxial stabilization. Multi-level OPLL, if you come from front, you have killed the person. If you come from behind, you have not done any favor to the person. If you do fixation, you have cured him. You have given him new life and you have given him new limbs and hands, and he will be happy in the immediate post-operative period. That is my guarantee for you. So to do decompressions in OPLL is a negative treatment. Anterior surgery is negative. Posterior surgery is negative. Only stabilization. So I introduced this concept before you, atlantoaxial and subaxial cervical fixation. It can revolutionize the treatment of cervical myelopathy related to OPLL. I use this Camillage technique for fixation. This technique has not been used very often. It is a most beautiful technique, quick technique, and many Egyptian friends have also come to my department to witness this operation. Such easy operation, I can tell you, and such strong point of fixation. I introduce sometimes 2 screws and call it double insurance fixation. Sometimes I introduce 3 screws in lumbar spine. I call it triple insurance fixation. So my summary before you, my dear friends, is can decompressive laminectomy become historical? I am saying yes. Is instability the nodal point of pathogenesis of both cervical spondylotic myelopathy and OPLL? My answer to this question is 100% yes. And there is no confusion in my mind. And those who are having confusion should remove that confusion. And those where confusion persists, please come and spend 1 or 2 months after Corona goes from India, and I will take you to another world of spine surgery. Like transoral decompression, I removed it from the dictionary of neurosurgery. Similarly, I am saying today in front of you, not today, not tomorrow, not day after tomorrow, but in 10 years, anterior cervical surgery will find space in history books. All kinds of laminectomy, laminoplasty, anterior surgery, anterior instrumentation are have to be condemned because they are harmful. So from only decompression to only fixation, a century-long journey of cervical and lumbar degeneration has now ended, and the treatment of OPLL and cervical degeneration is atlantoaxial and subaxial spinal fixation. So the final word for you is compression is never primary. Compression is not the issue. Decompression is not or never the treatment. Instability is the problem and stabilization is the treatment. Thank you, my dear friends. And this is, you see, I got this beautiful thing from one of my patients. She has written Spine Bright, and she has said that this enlightenment she has got in her life, and I say this enlightenment of spine surgery, all young and old neurosurgeons should get and revolutionize our field of spine surgery. Thank you very much.
Thank you so much, Dr. Gold, for your revolution lecture. Because we are short time, I will ask you two questions highlighted by our attendees. The first one regarding instability. How you decide this case is due to instability? Is it flexion extension, plain X-ray? Is it dynamic MRI? What about the clinical manifestation of instability that you want to highlight for our attendees?
Yes, this is a very, very, very absolutely important question. You see, this instability is in the facets. It is lateral to the midline. It is instability in the facets, even very high class radiology or MRI or CT scan will not be able to show you. Dynamic flexion extension imaging will not be able to show you instability. It is in your mind. You have to understand this problem. Instability with the validated parameters described in the literature will not be relevant to show you unstable cervical spine or unstable lumbar spine in degenerative spine. When you see an osteophyte, it is unstable. When you see ligamentous flavum bulging, it is unstable. When you see disc space reduction, it is unstable. When you see facetal listhesis, it is unstable. When you see pathological fusions of the bone, it is unstable in the cervical and lumbar and thoracic spine. In craniovertebral junction, whenever you see musculoskeletal abnormality, whenever you see short head, whenever you see torticollis, clipple file abnormality, platybaseus, bifid atlas, os odontoideum, and a huge number of problems. You don't have to see dynamic images to find out whether it is unstable or not. They are indicators of instability. When you see Chiari malformation, you don't have to see the facets. It is an indicator of unstable spine. When you see syringomyelia, you don't have to see the facet or dynamic imaging. It is an unstable spine. You have to do stabilization. You have to get this concept. You have to get this idea. It is not radiology, it is beyond radiology.
Thank you so much. So